We described the pharmacokinetic, pharmacodynamic, and toxicodynamic properties of antifungal agents and explained the pathophysiology and clinical presentation of candidiasis and aspergillosis. Now, given a patient with invasive candidiasis, let's recommend guideline-concordant treatment. Here are the 2016 IDSA guideline for management of candidiasis. So essentially for candidemia, this is what we're going to focus because there are different types of candidiasis, so including candiduria, candidemia, endocarditis, etc. We are going to focus on candidemia, which is candidiasis in the blood, because that's the most common one. So first line recommendation for empiric treatment of candidemia is echinocandin. So either a caspofungin, micafungin, and anidulafungin. So it doesn't matter which one. Typically hospitals have only one of them on formulary, so it's just a matter of which one is on formulary at the hospital. And then for alternative, in selected patients, including those who are not critically ill and who are considered unlikely to have a fluconazole resistant, then fluconazole can be used. And of course, another alternative is lipid formulation, amphotericin B. It is reasonable if there is intolerance, limited availability, or resistance to other antifungal agents. In other words, if you don't have an echinocandin on formulary and somebody has contraindication to fluconazole, either because they cannot tolerate it, QTC prolongation, and other things, then lipid formulation of amphotericin B would be your option. And that's because amphotericin B is very nephrotoxic and we want to avoid it as much as possible. Now, some laboratory tests that are recommended, of course, we want to, because this is empiric treatment, you want to test for azole susceptibility. So even though we start, let's say micafungin empirically, we want to test for azole susceptibility in order to be able to transition from echinocandin to one of the azoles, primarily because echinocandins are IV only. So if you are to send the patient home, you need an oral option, and your oral option would be one of the azoles, but you need to know if they are susceptible. And testing for echinocandin susceptibility should be considered in patients who have had prior treatment with an echinocandin. And that's because resistance in echinocandin is quite rare. So unless somebody has been exposed to it, it's unnecessary. And especially with glabrata and prapsilosis are more likely to have higher MICs for echinocandin. So if somebody has Candida albicans, for example, it's unnecessary to check echinocandin, but with these two species, it's more helpful. And of course, we need follow-up blood cultures. They should be done at every day or at least every other day, because that's how you know what's the first day of treatment. So if you are to treat the patient for 2 weeks, day 1 starts on the day that you get a follow-up culture that's negative. So if you keep getting daily cultures and the culture continues to be positive, your day 1 hasn't started yet, even though you've been giving echinocandin to the patient. But then on the day that you have a negative culture, that's where you mark it as day 1. And then, if you are to treat the patient for 2 weeks, starting from the day that the follow-up culture was negative, you do treatment for 2 weeks. Now, the step-down therapy. So hopefully by the time, this typically happens, within 5 to 7 days of empiric therapy. So it is, depending on what was used empirically, most patients will be on echinocandin, or if they were on amphotericin B, you want to transition to fluconazole in order to have an oral agent. And then, of course, if it's Candida glabrata, typically the MICs are higher for fluconazole, so a transition to a higher dose fluconazole, or if the MIC is so high that fluconazole is resistant, then high dose voriconazole would be another option. For Candida crucei is just resistant to fluconazole, period. So if somebody has crucei, fluconazole is not an option, so the oral option would be voriconazole. And duration of therapy, as I mentioned, is typically 2 weeks after documented clearance of Candida species from bloodstream and resolution of symptoms attributed to candidemia. So 2 weeks is minimum. Of course, clinical judgment must be used. So if the patient has not had resolution of symptoms, longer duration may be necessary. Now here's a visual of the recommendation. So essentially, for most patients, empirically, echinocandin is what's prescribed for patients. And then once the species are identified, depending on susceptibility results, the patients may be transitioned to fluconazole for oral, so especially albicans. But then for glabrata is where we get a little problematic. So including if glabrata MICs are too high for echinocandin, even empirically, we may need to go to amphotericin B. But then for step down, either voriconazole or high dose fluconazole. Crucei, of course, voriconazole is the only option. And then most recently, we've had Candida auris. So this is not in the guideline because Candida auris started to emerge, later on after the guideline came out. But essentially, echinocandins will still work. But we have very limited option when it comes to azole. So it's just a matter of which one of the azoles happen to be susceptible. Candida was susceptible to for oral step down. So this is from the CDC specifically for Candida auris. They showed that the rate, the incidence of Candida auris is on the rise, so it's continuing to go up. And what's concerning about Candida auris, and they have urgent threat level for this, is that 90% of Candida auris isolates are resistant to at least one antifungal, and about 30% of them are resistant to at least 2 antifungals. And it's we're not sure in the next few years if this resistance will get worse or just stay the same.